Good afternoon. Welcome to the Student Faculty Seminar of the Presidential Lecture Series and to the Philosophy Forum. It's my pleasure this afternoon to introduce Professor Andrea Louise Campbell. She is department head and the Arthur and Ruth Sloan Professor of Political Science at the Massachusetts Institute of Technology. Her work is in social welfare, and her most recent book, which was really well received, is titled Trapped in America's Safety Net, One Family's Struggle. This is also the topic of, and the title of her talk this evening at 8 in the Denison Theater. Her topic this afternoon is Why So Little Policy Movement in Caregiving Issues, a Policy Feedback Perspective. Please join me in welcoming Professor Campbell.
Well, thank you very much for that kind introduction, and thank you so much for the opportunity to speak here today. I'm just delighted to be here, and I want to thank the President's Office and Richard Drake, Rob Saldine, who made this visit possible as well, and Chris Musty, who some of you may know in political science, whose idea it was to invite me out in large part, and I'm just thrilled to be here. So I'm a political scientist who studies social policy and health policy and tax policy. And I thought that for this multidisciplinary audience, where people are coming from a variety of interests and experiences, that I would share an essay that I've been working on, in which I need some help, that discusses some glaring holes in American social provision. And I'm talking about what we might call caring issues, especially child care and elder care. Most American women, and not only women, but primarily women, experience significant spells of caregiving for children and or for older relatives. And men participate as well, but the brunt of care within families is still mostly borne out by women. At the same time, as you know, most American women work outside the home, often out of financial necessity. And despite the ubiquity of these arrangements and the challenges and the cross pressures that they create for many women and men, public policy, as currently stated, falls woefully short in helping people and families fulfill their work and family obligations. And there's been surprisingly little policy change over time, over the last several decades, despite the greater need arising from women's increasing labor force participation and from the aging of the population. So this policy stasis is even more puzzling in light of the fact that women's educational attainment is increasing. Women now earn more college degrees than men. In many households, they earn more income than men. And increased political participation of women. Women now outnumber men at the ballot box as well. And so what I want to do today is examine this puzzle of policy sclerosis around caregiving through a policy feedbacks lens. So what is policy feedbacks? It's a theory or a paradigm that a number of us in political science and sociology use these days that arises from the observation that policies create politics, which is to say that policies that are in place reshape the political environment. They have effects on lawmakers, on interest groups, on members of the public in a variety of ways. Existing policies provide resources to some actors in the political environment over others. They provide different kinds of incentives. They reshape views about what good policy is. Existing policies might create budget constraints that shape what is possible in the future. So there's a bunch of mechanisms by which existing policies sort of shape the possibilities for subsequent policy. constrain future action, basically, and might help explain the lack of policy movement in an area such as childcare and elder care. And so what I want to do is walk through some of the shortcomings of existing policy in childcare and elder care, talk a little bit about alternative explanations, and then discuss the ways in which this policy feedbacks paradigm might help us understand why there hasn't been more policy movement in this area. So, shortcomings of existing policy. So the majority of women of all ages work outside the home, including the majority of mothers of children, and the majority of family caregivers for older adults. So here you can see that among mothers, the labor force participation rate is way above 50%. Even for infants, 57% of mothers work, and that ranges up to 3/4 of mothers of school-aged children between 6 and 17. So the majority of mothers work. Also, when we think about elder caregiving, at any one time, about 20% of American women are caregivers for older relatives, and 2/3 of them had work, paid work outside the home, at least at the moment that caregiving episode started. And so we've got many women with significant spells of childcare and caring for older relatives trying to balance these obligations with paid work. And yet the United States lacks a lot of the supports that we see in other countries that help people, that facilitates balancing family and work obligations. So let's talk for a moment about, do I want to do this? Yes, the shortcomings of existing policy. So in childcare, we have sort of two systems that are inadequate in their own ways. And if you think about it, the universal model of K through 12 free public education that we have has never filtered down to care for younger children. Our existing system is composed of subsidized daycare for low-income children, and then a private system of child care for pretty much everyone else that's subsidized by some tax credits. Now, both of these systems are inadequate to current need. For low-income children, because of low funding, the means-tested programs for poor children that might provide daycare only provide enough slots for 18% of eligible children, so fewer than 1 in 5. Despite the fact that the 1996 welfare reform made working a condition of getting cash welfare, but without the child care that would make that work possible. So that's what happens on the low-income side of the equation. And then public help for middle-class families is limited to tax credits. Those tax credits have not kept up with the cost of the cost of child care. In many metropolitan areas especially, they're actually a fraction of the value of what it costs every year for daycare. There have been some states that have experimented with pre-K programs for 4-year-olds, but these are mostly educational programs. They're not really daycare. And so they typically run just a few hours a day and only during the school year, so they don't really match work hours. They're not really meant to be daycare. And so in the virtual absence of public provision for childcare, there's been a large industry of private childcare that has arisen. These tax credits offset some of that cost. There are a few employers that subsidize childcare for their employees, although those benefits are typically only available to pretty high-income, high-level employees. So given this spotty public help, whether you're talking about low-income children or middle or upper-income children, many families at all income levels mostly rely on informal childcare arrangements, which are also almost completely unregulated. And so basically most families are facing this mismatch between childcare needs and public help, not to mention, the ubiquitous concerns about the availability of slots and the cost and the quality. So that's kind of the status quo on childcare. Now, on elder care, we have a number of shortcomings as well. So it's important to note that neither private health insurance, like you might get from an employer, nor Medicare covers long-term care. And by long-term care, I mean the kinds of supports and services you need to meet the activities of daily living. Bathing, dressing, toileting, eating, and so on. And so that's not covered by private health insurance or Medicare. There is public provision available through Medicaid. Medicaid is a means-tested program, which means that if you're an older person in need of nursing home care or home health care, you have to spend down to the poverty level in terms of income and assets to be eligible for Medicaid. And family members cannot help a Medicaid recipient financially. For example, families can't top up this public Medicaid benefit in order to get their older relative into, say, a better quality nursing home or a nursing home with an Alzheimer's unit. Medicaid doesn't pay for those fancy things. And the thing about the current policy, it's either a black and white choice. Either Medicaid pays 100% or the family pays 100%. You can't do a top up. Now, there is a private market of long-term care insurance, but it is pretty flawed. The premiums are quite expensive if you've ever looked into it, and the daily benefits are modest, and they're time limited. These programs are really meant, usually they're capped at 3 to 5 years, and there's usually an overall cap in the benefit as well. As a result, fewer than 6% of Americans 45 and over have private long-term care insurance. And such policies only cover 1% of all long-term care expenditures in the United States. The other thing about this industry is that it's faced tremendous consolidation over time. So a dozen years ago, there were about 100 insurance companies that sold these private long-term care policies. Now there's 10. And so the other concern you might have as a consumer is if you buy into one of these plans, is it going to exist in 20 years when you need it? So as a result of most public care being means tested and private long-term care insurance being a flawed market and very small, the vast majority of long-term care in the US is provided on an informal basis by family members. In fact, about 2/3 of older Americans who need long-term care rely exclusively on family and friends to do that care. Now, this has a toll on caregivers, right? Most caregivers are middle-aged and older women who were in the formal workforce, in paid work, when the caregiving episode started. Many have to cut their hours or leave work altogether because of the all-consuming nature of many caregiving obligations. Oftentimes, they help pay for their older relatives' household and medical needs on the sly. Actually, it's not on the sly if you're doing family care. It's on the sly only if you're in Medicaid. But if you've already cut your work hours, obviously you might face a financial crunch if you're helping your older relative at the same time. There are no tax credits to offset such costs. And not only do caregivers face a financial hit, but they also jeopardize their own retirement security, because if you're working fewer hours or not at all, your own future Social Security benefits will be lowered because of the Social Security formula for benefits. And in addition, caregiving is can be very emotionally and physically taxing, well beyond the financial consequences. It's a really difficult thing to do. And there are very few supports, such as respite programs, to give caregivers a help, and things like adult daycare programs or other kinds of programs that might alleviate some of the 24/7 aspect of caregiving. Those kinds of programs are very spotty and not consistent across the nation. So that's sort of a rundown of the shortcomings in existing policy. You might wonder, what do other countries do, before I get to my explanation of why it is this way. In many peer nations, there's actually universal preschool. There's even daycare in some nations for children under 3, not to mention paid maternity and parental leave, paid sick leave. There's also regulations in many peer nations, and by this I mean advanced industrialized nations, our rich peer nations. There's also regulations in many of these countries that make for a smaller gap in wages between part-time and full-time work. Because in the US, there's quite a large gap. And it's very consequential in the US if you work part-time, because oftentimes that means no employer-provided benefits as well. And American women and American men lack these supports with tremendous economic consequences. So take American women, they're about as likely to work as European women, but they're more likely to work part-time than full-time, in part because of the lack of child care supports. And compared to full-time positions, American part-time jobs pay lower wages and provide fewer benefits, unlike peer nations where that wage gap is smaller. And of course, in the US, many fringe benefits are provided by employers or not, if you work part-time, whereas those kinds of benefits are provided by the government in our peer nations. So if you look, in the absence of these protections, we know there's a big gender gap in wages in the United States between men and women that's almost entirely due to mothers. Women without children earn the same as men. So that's the toll that these lack of supports takes. Now, caregiving for the elderly, that's a huge challenge for every country, because in most of these countries, we've got this, ratio of retirees to workers that's growing over time. And in fact, the US is in some ways demographically better off. We have a less aged population than many peer nations. But in other countries, even this policy area, provision is far from perfect, but it's wider than in the US. So for example, in Germany, the Netherlands, Japan, and Korea, there is social insurance for long-term care. Workers pay a payroll tax, just like we do for Social Security, but it covers long-term care, covers disability and old age. And then long-term care is just folded into the universal health care systems of other countries, like Belgium, Sweden, Norway, and Denmark. So, and again, the caregiving obligations in the US have big economic consequences for American women. American women, if they take time out of their working histories, as we mentioned before, end up with lower Social Security benefits. If you look at senior poverty rates across countries, on the one hand, in the US, senior poverty is much lower than child poverty, in part because of Social Security and Medicare. But when you look at senior poverty in the US versus other countries, it's much higher in the US, in part because we've got a lot of older women who were caretakers and have weak earning histories in a formal sense and have very low Social Security benefits and are in poverty and old age. So the precarious economic situation of women of all ages because of child care and elder care obligations is exacerbated by this lack of public supports. So there's mostly policy sclerosis here, despite these yawning needs. In terms of child care, there was a Nixon-era proposal for universal preschool that was quashed. The 1996 welfare reform that I mentioned allows states to use the welfare block grant that they get. They get a certain set amount of money. They can use some of that money for child care for welfare recipients. The thing about the block grant is that it is frozen at 1995 levels. It's not adjusted for inflation, so it's lost about half of its value over time. So states don't have a lot of money to finance child care for their welfare recipients. On the elder care front, in the 2010 Affordable Care Act, the Obama health care reform, there was a social insurance program for long-term care called the CLASS Act, the Community Living Assistance Services and Support Act. And Rob Saldin has written a great book about the CLASS Act and its demise. So the CLASS Act, the way it would have worked is that workers could elect to join CLASS, and you would pay a payroll tax in, and that after you were vested for 5 years, if you became disabled, you could get a daily benefit that might help offset the expense of nursing home care or home health care. The problem with the CLASS Act is that it was a voluntary program. It wasn't mandatory, and any kind of health insurance type program that's voluntary suffers from adverse selection, which is to say the people most likely to need it are the ones who are most likely to sign up. And so your potential payout is much higher than the revenues coming in. And so the Secretary of Health and Human Services declared the CLASS Act fiscally unsustainable, and then it was actually repealed in the fiscal cliff bill at the end of 2012. So briefly, we had social insurance for long-term care, but it was axed before it ever came into effect. So the main policy initiative that we've had in the last many decades around family caregiving was the 1993 Family and Medical Leave Act. And it was heralded at the time for providing 12 weeks of leave for workers with a new baby, or caring for a family member who was ill or disabled, or even taking time off work themselves if they were ill. The problem is that this legislation, even though it's been in place for 20 years, has proven ineffectual for a lot of workers. The eligibility requirements are pretty strict. You only are eligible for this leave time if you've worked more than 1,250 hours, which is slightly more than half time. 2,000 hours is full time. So you have to have worked more than 1,250 hours for a firm of more than 50 employees to even be eligible. So that's only half of American workers to begin with. And then surveys show that most people who are eligible can't afford to use it because the leave is unpaid. You know, it's really hard to take 3 months off of work and not get paid. Now, in recent years, there's been some state innovation. Several states have passed paid family and medical leave programs. So depending on the state, this is either 4 or 6 weeks of paid leave to take care, again, of a sick family member, a new baby, et cetera. So these programs now exist in California, New Jersey, and Rhode Island. These are states that already had a short-term disability program, and they were able to layer this paid family leave on top of that existing program. Business groups objected to this reform, saying it would be, you know, I guess a deterrent, increase payroll costs and so on. But it turns out it's really been pretty much a non-event for businesses. The way this is mostly financed is by payroll taxes on employees. And it turns out because people now have access to paid leave in these states, it has reduced employee turnover and therefore payroll costs for a lot of companies, and it's greatly improved employee morale. And it also increases, for say, new parents, time with children, increases rates of breastfeeding for new mothers, and so on. So there's a few state legislatures that are currently considering paid family leave bills, but otherwise, family caregiving needs have been pretty much ignored by lawmakers. So how can we explain all this? So there's some usual explanations that political scientists turn to that I'm not going to spend a lot of time on because I want your help on this at the end. Traditional explanations are we don't do more expansive social policy because of attitudes towards government in the United States, which is to say Americans prefer small government, oppose government intervention. You know, the thing is, social insurance, like Social Security, Medicare, quite popular. Two of the most popular things that government does. So Americans are what we call small government abstract conservatives. You know, they give a small government answer when asked about the size of government or the appropriate role of government in an abstract sense. But then when you start asking people about specific programs, you'll get large majorities who are like, yeah, that's a pretty good program. We like that. So that's sort of the operational liberal side of the American kind of Janus-faced orientation towards government. So attitudes towards government can't explain everything. Another possibility is attitudes towards women and women working and traditional gender roles. And this I don't have a definitive answer for, other than the fact that no matter what people's attitudes are, most women work. And so the reality may not square with attitudes. Another possible alternative explanations is just our political institutions. It's really hard to pass new policy in the United States because we have a lot of hurdles in the legislative process. And so it's very easy to let policy stay static. That's far easier than policy change. And I think there's explanatory policy or explanatory power in several of these alternative hypotheses, but I think that the kind of frame I'm about to describe to you, this policy feedbacks approach, can add to our explanatory arsenal. In some way, it incorporates some of the elements here, but I think also adds. And in the end, you can tell me whether you think that's right, and if there's any other alternative explanations that you can think of for why there's not greater policy movement in these areas. So briefly, let's not get to that quite yet. I talked a little bit about what are policy feedbacks. So the idea is that existing policies reshape the political environment and there's possibilities for subsequent policy making. For those of you who are political scientists, probably not too many of you, this is a little inside baseball. This whole idea built on earlier work by political scientists like James Q. Wilson and Ted Lowy, and they looked at different kinds of policies, made these policy typologies, and showed that different types of policies generate different patterns of political mobilization. So they looked at policies that have concentrated or diffuse costs or benefits, or they looked at policies that were distributive or redistributive. That these different kinds of policies meant different things for political mobilization. And then later, political scientists like Theda Skocpol, who's at Harvard, and Paul Pearson, who's at Berkeley, showed that public policies are not just the products of demand or sort of function, but the products of existing policies. Because existing policies shape the interests of various actors in society. They shape the choices that politicians may make. They shape the resources that bureaucracies and interest groups bring to bear when they're shaping policy. And existing policies also affect members of the mass public, shaping their attitudes about what's good policy. They might confer resources like money or free time to certain members of the public. And the whole idea is that existing policies might affect these notions about what works. They might impose budget constraints because they've already spent the money. They might undermine political momentum by sort of half-solving problems. And those are the kinds of effects I want to kind of walk through right now. So I'm going to talk about policy feedback effects with regard to three kinds of actors. Lawmakers, like elected politicians who are mostly legislators, interest groups, and then members of the public. And then I'll finish up, and we'll have Q&A. So feedback effects in lawmakers. So how do existing policies affect how lawmakers approach legislating? So one effect is what I call the tyranny of half solutions. So lawmakers can point to existing policies and say, well, we have done something, even if those policies are inadequate. So in long-term care, you can say, we have a policy, we have Medicaid. We haven't done nothing on long-term care. Or there are tax credits for child care. We haven't done nothing on child care. And the problem is that existing policies are inadequate, but they're also pressure relieving on lawmakers. Their very existence undercuts the urgency for change, because at least government has done a half solution, even if not a full solution. So that's one kind of feedback effect that affects lawmakers. Another is the budget constraint imposed by past policies. So when we see this on both the tax side and the spending side in the United States, so if you look at tax revenues of the US, especially in international comparison, tax revenues are quite low, and they've been flat over time. So if you go back to 1965 or the mid-60s, you'll see that tax revenues in the United States as a percentage of GDP are about the same as other advanced industrialized countries. And then over time, our tax revenues stay flat. And sometimes when they go up a little bit, they go back down because of tax cuts, like the Reagan tax cuts or the Bush tax cuts. Tax revenues in other countries have gone up over this period when there's been sort of new social needs, like the need for childcare as women have gone to work and so on. And so, other countries, as they've seen new social risks because of women's increased labor force participation and increasing rates of divorce and lone motherhood, as they call it in comparative politics, those welfare states have grown in size, but the US one has stayed the same. So there's that budget constraint of just what does the revenue side look like. Another budget constraint of existing policy is the crowd-out effect of healthcare spending. So the United States spends a tremendous amount on healthcare. If you look across all social policies, healthcare is the big enchilada. So we spend more than twice as much as a percentage of our GDP as the next highest nation. And there's lots of reasons for that we can talk about in the Q&A. But we spend a lot on healthcare. So this crowds out a lot of things. Just over half of Americans get their health care through their employer. And so if you're an employer offering health insurance to your employees, you get a tax break for that, but it's expensive. And it might undercut your interest in offering other kinds of benefits to your employees, like paid vacation, or paid maternity leave, or paid parental leave. So there's that crowd-out effect. And then there's the more societal-wide crowd-out effect. Economists note that in the United States we've had increasing productivity over time, which is to say that each worker creates more economic value on a per capita basis than used to be the case. almost all that productivity has been sucked up by healthcare costs. It hasn't gone to worker wages. Worker wages have been flat or declining in real terms in the US. So if we weren't spending so much on healthcare, we might be able to spend more money on other things. The third kind of crowd-out effect is something that a health policy expert, Miriam Lageson, who's at Columbia, pointed out to me, which is that a strong driver of healthcare costs in the United States are the prices charged by physicians and hospitals, which are far higher than the prices charged in other countries. And Miriam points out that healthcare costs around the world started going up in the 1970s, in part because of the aging of populations, in part because of advances in medical technology. But governments in other countries, because of the way they run their healthcare systems, had levers to keep a lid on that healthcare spending, whereas in the United States, we have no such lid. And so healthcare costs have gone up dramatically here. And then if you look specifically at what physicians and to an extent hospitals have done, Medicare and Medicaid, the public health insurance programs for senior citizens and for poor people, were enacted in 1965. And to prevent physician opposition to those programs, reimbursement levels were set at very attractive levels for physicians and hospitals. And so physicians locked in, especially, locked in this very favorable economic model and captured a good share of all healthcare spending at precisely like right before women started going to the workforce and before we had these new social needs around childcare and elder care. So basically, healthcare balloons at exactly the time when we need that money for other things. So that's the crowd-out effect. Another effect on lawmakers could be for them to say, you know, rather than spend more on, say, elder care by having a public long-term care insurance besides Medicaid, is we already spend a lot on the elderly in the United States. So if you look across peer nations, pensions and healthcare spending dominate welfare states everywhere. It's just a fact of advanced industrialized life. And so all these welfare states spend more on the elderly than on working age people, but that skew towards older Americans is much greater in the US than in other countries, mostly because most of the welfare state spending we do have is for the elderly. Social Security and Medicare are way bigger than any of the means-tested programs that go to the working age poor. And so from the lawmakers' perspective, it's like, you know, any interest they might have in expanding benefits for the elderly, like going to long-term care, is kind of dried up because of this very large ratio that already exists. And then finally, for lawmakers, existing policy could change their feelings about what good policy is. So think about this. Why don't lawmakers allow families to top up Medicaid? Like, wouldn't it be nice if families could use a Medicaid benefit for most of a nursing home, but then, you know, pay a couple $1,000s more per month to allow their elderly relative to live in assisted living or a better quality nursing home or one with an Alzheimer's unit? Most families can't afford to pay the entire bill, but if there was like a public piece that they could top up, then they could get their older relative into the kind of care that was appropriate for their needs. But the barrier seems to be that in lawmakers' minds, that these social assistance programs that are means tested, or these social assistance programs like Medicaid have to maintain this tight means testing. You know, that we can't make these things universal. So that's really, you know, unfortunate that we can't change things in that way because of these sort of notions of what good programs are. So, you know, we've got this tyranny of half solutions and budget constraints and notions about what good policy is that I think undercut lawmaker interest in addressing long-term care and child care needs. So what about interest groups? There's huge feedback effects here. So interest groups, and by this I mean child care chains, I mean nursing home operators, which are also in chains these days. Interest groups have figured out how to operate in the status quo, and they oppose change because they've got business models that work for them right now. And the permeability of the American government system to interest groups gives them plenty of opportunity to exert political influence and get their preferences fulfilled. And since their preferences are status quo, that's pretty easy to get fulfilled. So there's a big commercial childcare industry, and it's grown substantially over time as women have gone into the workforce. So for example, the number of childcare centers doubled between 1982 and 1997, and I'm sure have gone up in the 20 years since then as well. And as expensive as childcare is, middle and upper income women can afford it because it's a little subsidized by the tax code, as we've noted. Sometimes it's subsidized by employers. And you might imagine from the perspective of childcare operators, especially the big chains, they might oppose more public provision because that might pay a lower rate than what they can squeeze out of private payers now, right? So that's one reason why we may not get movement on childcare. The other thing about the childcare operators is that if there were more public provision, there might be more scrutiny about things like quality. The childcare industry right now relies on a low-wage workforce. It's one of the worst paid sectors in the economy. That's facilitated by the low minimum wage. And there's also a lack of rigorous quality standards in many states, and there's no federal standards for childcare quality. So that's the childcare piece. The nursing home industry has also figured out how to operate in the existing environment and might oppose change. Now you might think, wouldn't the nursing home industry prefer social insurance over social assistance, Medicaid, which is what exists now? Because wouldn't social insurance pay more than social assistance? They might. But on the other hand, a universal social insurance program might reimburse at lower levels than, again, what nursing homes can extract from private pay patients now. The other thing about the long-term care industry is that not only is it dominated by nursing home chains, but more recently, venture capital has gotten involved and interested in nursing home chains. And they bought up a bunch of nursing home chains and home health care agencies, and amazingly are managing to squeeze some profit blood out of the Medicaid stone by cutting staffing levels in nursing homes and keeping wages really low. And they don't want another public payer looking over their shoulders at quality either. So providers in both of these areas, provider interest groups in both of these areas have figured out how to be profitable. They don't have necessarily a lot of interest in greater public provision, in part because private pay customers are pretty lucrative and more public pay might invite more scrutiny on quality. The other piece of the interest group story is, well, what about interest groups for consumers? Where are all the people, championing working mothers or championing elder caregivers? Well, there aren't any. AARP kind of holds long-term care at arm's length. AARP is interested in Medicare and Social Security and interested in policies for active seniors. Long-term care, not so much, because then you're talking about disability and senescence and things that AARP doesn't want to talk about. And there's no organization pretty much for organizing mothers. And feminist organizations have really focused on anti-discrimination policy, done much more of a legal strategy, not so much on social provision like childcare. All right, the last thing. Well, what about the public? We live in a democracy. There should be, pressure from the public for policy change. If the public wants policy change, why aren't members of the public agitating for change? Because we're talking about tens of millions of people in these situations, right? And I think the feedback effect here is the demobilizing effect of current policy. So think about childcare. Kimberly Morgan, who's a policy analyst at George Washington University, says our private system of childcare is politically self-reinforcing. And that's because middle and upper income women who are most likely to be active in politics have figured out how to make the system work for them. And so that undercuts the constituency for change by taking out of the political equation those who would be potentially most active. And then for long-term care, the constituency for change is undercut there too. And there's two aspects of existing policy that I think undermine caregivers' likelihood of agitating for change. One is, and of course, this is even above and beyond the fact that if you're an elderly caregiver, it's like an exhausting experience and not one in which you want to do a lot of, policy activism. And then when your caregiving episode is over, it's typically because your elderly relative has died. Also, not an auspicious time for engaging in political activism. But above and beyond those kinds of effects, there's two policy effects. So one is the confusion created by our federal system of government. So we do have some programs for caregivers, for the elderly. Some are at the federal level, some are at the state level, some are at the local level. If you wanted to agitate for change, where would you go as an activist? Like, which government would you press your claims on? Who knows? And Sandra Levitsky, who's a sociologist, has interviewed family caregivers and found exactly this, that people just don't know where they would press their claims. The other problem is, would they know what to ask for? And the nature of existing policy creates a second barrier, which is that, we have our social welfare state is so small in scope that it's hard for people don't have examples of like what would work and what to ask for. And Levitsky shows that having no viable models, that even the people that she identifies as wanting change have no idea what policies would help. And I call this lack of policy imagination, which is perhaps a little bit cruel because it makes it sound like it's the fault of the individuals. It's not really their fault. But it's that existing policies determine the parameters on which we think, and it's really hard to think outside the box, especially if you don't know what the alternatives are. And there are other models out there, like social insurance for long-term care, like they have in Germany, in which we head for a blink of an eye in the Class Act. But none of Levitsky's interviewees brought up that. They couldn't even think of, broader respite care or broader adult daycare or anything. So that's the lack of policy imagination, I think, is another thing that undermines the push for political change. And then the last thing, there's another way in which existing policy undercuts movement on policies, and that's that the people who know what would help are social service providers, like case workers who work for nonprofits, for example, but they're prohibited by law from lobbying for change, or they could risk their nonprofit status. And so that undercuts political mobilization too, the fact that people who know what to ask for are silenced in our system. So, I think that existing policies shape a lot of things in our politics and undercut the possibilities for change. They shape what lawmakers think is good policy, they impose these budget constraints, they create stakes for interest groups, such as nursing homes and child care providers who learned how to do business under existing conditions, and they capitalize on the American permeability of the American system to keep it the way it is. And then, as we just mentioned, policies undercut constituencies for change. As citizens learn to deal with the status quo, particularly the more affluent, who can best afford these private systems, but who otherwise would have been the most vocal. And it's low-income families who are most disadvantaged by the status quo, but their needs are the most easily ignored in the American electoral system. So, the challenge is moving these needs onto the political agenda. So I'm going to close with this. I have 3 requests of you. So I need help with 3 things. So one is, are there other competing hypotheses about why there's not more agitation for change in these areas, child care and elder care, where there's just such need? So I'm really curious what you all have to say about that. For those of you graduate students in the audience, how do I test my explanation against competing alternatives? And then, a third thing, maybe I should ask this of my political science colleagues, how do you take a concept like political policy feedbacks and make sure that it's not so capacious that it incorporates everything? Because then it's just like this big flabby concept that doesn't actually help you. So those are my 3 questions for you. So thanks for listening, and I'm really curious what your comments and questions are. Thanks. Yes?
Have you thought about how your concerns fit in with the centrist neoliberal orientation of the Democratic Party in recent decades?
That's a really good question. So, you know, Democrats have increasingly kind of moved to the center in the designs of their social programs because I think they see that designs of that are further left are not going to garner enough support. And one kind of policy design that has become very common in recent years is to provide incentives for people to enroll in programs that incentives and not mandatory requirements. So for example, when Medicare was expanded to include prescription drugs about 10 years ago, it could have been the case that the prescription drug benefit was just folded into Medicare, and that would have been a mandatory design. But instead, this sort of neoliberal design is more like, no, let's do it through a market mechanism and provide an incentive for people to sign up for this, but not make it mandatory. And so the way the prescription drug benefit is carried out is through a separate prescription drug plan that a senior citizen has to select and purchase above and beyond regular Medicare. And if you don't sign up for one of those prescription drug plans, it's not mandatory, but the incentive is if you don't sign up when you're eligible, then your premiums go up by 1% per month for every month that you delay forever. I mean, your premiums go up forever. So if you delay by 2 years, your premiums will forever be 24% higher than they would have been if you'd signed up at the moment you're eligible. So the idea is like to incentivize people as opposed to force them. But the problem is in something like long-term care, the Class Act was voluntary, and as we observed, only those people who need it will sign up. Whereas, you know, especially in something like health insurance, you need to maximize the risk pool. So you need mandatory. Mandatory is what gives you the maximum risk pool. And so one of the costs of sort of the neoliberal move in policy designs, and both Democrats and Republicans have been using these neoliberal designs, is that they're about incentives and not mandatory. And mandatory is sometimes what you need, especially in social insurance, because social insurance is only insurance if it's truly social. Anybody else? I've shocked you into silence. Yes.
I wonder if the community society distinction might cast some light on the issue. All people, I think, in the advanced industrial countries have gotten used to the development where community responsibilities have been taken over by large social agencies when it comes to food, clothing, healthcare. And in the European countries were perhaps small and homogeneous enough so that the idea that society should become the community writ large and take on the responsibilities that more or less were taken care of by communities, such as taking care of the elders, you know, relatives helping with children and so on, should be taken over by the society or the state. And then in this country, additionally, functions that were taken over by the state in Europe, such as railroads, airlines, and then healthcare, were taken over by private institutions, corporations in this country. Mm-hmm. And then perhaps there may be a residual community nostalgia in this country more than in others, where we think, let's not give up on communities altogether. You know, it's a nice thing if the families take care of their own. Mm-hmm. And the challenge then would be to reconceive community in a way that's not injurious the way it is here, and especially detrimental to women. And if we invigorate a notion that there are responsibilities that only the state can take over. I mean, healthcare is the prime example. It's just not made to be taken care of by private agencies.
Mm-hmm. Yeah, you know, as a political science confronting a sort of philosophical argument, there's many ways a political scientist could answer that. I mean, part is the sort of public opinion piece, which is that I think one barrier is, you know, concern that individuals might have about, you know, what is the proper role of the family, you know, and should it be the case that individuals take care of children, and then when you're older, you take care of your older relative, just as that older relative took care of you when you were a child, and so there's, you know, guilt associated with using public provision or just simply outsourcing care at all, you know, to whoever, whether you pay for it or the government pays for it. So I think that's a very strong sentiment for many, many people. So that's one thing. Another piece of sort of community versus society in the United States, which is very fraught, which of course is the, you know, this notion of, you know, racial and ethnic homogeneity versus heterogeneity. And there's extensive studies by economists in general that, you know, the more diverse a society, the harder it is to provide social goods and public goods because people are more amenable to paying taxes to support services that go to people perceived to be like themselves as opposed to people perceived to be others of some kind. That's why I think that in some ways that adds to the puzzle around child care and elder care is because, you know, who's affected by the paucity of public provision? It's like ordinary middle class white people, you know, and so you would think that universal programs might be appealing to them in the same way that Social Security and Medicare are universal and popular because they're universal, and people recognize who benefits, looks like them, and so I think that kind of in some ways adds to the puzzle to my mind. I'm sure I did not adequately address your question in the philosophical grounds. Yeah.
Just add some numbers to the prior comment. I've spent 36 years in healthcare finance in my career. The Medicare program spends approximately 7% on all administrative costs and 93% goes to patient care. In the private sector, if you count administrative costs, marketing costs, and profits, that number jumps to somewhere between 22 and 30% based on whatever study you look at.
Right.
So let's take a midpoint of 25%. So if you go from 7 to 25%, that's 18% of all healthcare costs are being, in my opinion, wasted that are available if we did have a public financed healthcare system like the prior speaker said. And take one more set of numbers. If we assume that 18% difference, and we could say, the healthcare system is currently 18% of our GDP. If we could save 20% of it, that's 3.6%. So if you look in those terms, we're spending 3.6% of our GDP every year on costs associated with healthcare that are not going to provision care.
That's right. You know, our current healthcare system is wildly inefficient in exactly the means that you say. You know, and that's why proponents of single payer are proponents of single payers, because it is more efficient if you have one insurer. I mean, politically, it'd be very hard to get there in the United States. I think that we have stomach for healthcare reform about once a generation. And so maybe if the ACA and whatever beautiful plan follows the ACA, ultimately devolves. In about 20 years, we're going to do another healthcare reform, and maybe we'll eventually get to a more efficient system. But you're right. If like we could use that 3%, 3.6% of GDP for some of these other social needs, you could do a lot with 3.6% of GDP. That's a lot of money that right now we're using like in a wildly inefficient way. Yeah.
Could you speak to your opinion on the efficiency of Obamacare? And the notion of the Republican Party to repeal it because they think it's inefficient?
Yeah, so, so the Obamacare is getting it from both the right and the left these days, right? So on the efficiency piece, it gets it from the left for the same thing. So what the politically possible way to expand health insurance was to leave intact the health insurance arrangements of people who had, coverage through Medicare, and then people who had coverage through their employer-based system, and then try to expand coverage to other people using these healthcare exchanges, and then in, well, now half the states, increasing eligibility for Medicaid. So that's what was politically possible, because it was too difficult to sweep away the private health insurance industry. But it also locks in the private health insurance industry. And it tries to make it more efficient along the lines of what this gentleman was saying by having this medical loss ratio provision, which says that insurers have to spend a certain amount of money on actual medical claims and not on administrative costs, to try to get that 25% number down to more like 10%. So the ACA tries to make the system more efficient, but it's also using a vehicle, many private insurers that are going to keep administrative costs high, because it's still going to be the case that providers, hospitals and doctors have to have billing people who are sorting through all the different health insurance, through all the paperwork associated with all the different health insurers. So it's still an efficient system in which there's some regulations that try to make it more efficient. What the ACA will be replaced with, I think, is an open question. And right now, I think the Republican Party and the new Trump administration is struggling to figure out what a replacement would look like. Because the other, irony of the ACA is the Republican alternative to the Bill Clinton health care reform proposal of 1993-94. So if you're already protesting against what was your alternative from 20 years earlier, what's the new version? It's a little unclear. I guess it's going to be high deductible health plans with tax credits for buying private insurance, but I think private insurance is still going to be the vehicle by which people get insurance. That's at least what it looks like at this point. Let's see, too many hands. Yeah.
Kind of a nuts and bolts question. You said, productivity per worker has increased steadily since about 1950.
Or it has increased.
1950 to 1980, I think roughly doubled.
Mm-hmm.
And wages adjusted also doubled pretty much in parallel. From 1980 on, productivity continued to rise and wages flatlined since then.
Yeah.
And you said that difference between those two was entirely eaten up by healthcare.
Well, there's another thing it's eaten up by, but go ahead and finish your question.
Huge number. Is that really what you did? I misunderstood.
So it hasn't entirely been eaten up by healthcare costs. It's also been redistributed to the top 1%. So that's the other piece of what's happened, is a lot of the productivity gains have also accrued to people at the very top of the income spectrum as well. So those two things are where those productivity increases have gone the last 30 years or so. So it's not all to healthcare. Yes, Peter.
So I'm not sure this is a competing hypothesis, or maybe it's a supplementary hypothesis, but what about, you talk about policy feedback, what about policy blowback? I think that's something we might need to be thinking more about at this point. Is that an alternative hypothesis, or is that something you could build in and maybe get a little more specificity to policy?
And so what do you mean by policy blowback? Like, do you have an example in mind?
Well, I mean, basically, Obamacare, I think. Obamacare created a backlash.
Oh, I see.
And I wondered if that is one of the things that's going on here that's really important.
Yeah, and I guess, what category is that? I guess in part it's public opinion, in part it would be lawmakers of the opposite party not happy with a new policy. Yeah, I suppose that could be included. I was trying to make the concept less capacious, and now you're making it more capacious. But less capacious, less, if the concept gets too broad, it's kind of like when political scientists try to just, to determine like why do people vote, and there's this model, like there's costs and benefits, and of course the cost of voting outweighs the benefits of voting, right? Because the costs are you have to go and vote, and it takes time, you got to learn about the issues and the candidates, and the benefits of voting are relatively small. So this is sort of an economist view of voting, and so the way the economists get around the fact that people still vote, even though the costs of voting are higher than the benefit of voting, is they say we have what we call the D term, duty, and everything gets loaded up on duty. That people's civic duty is what drives them to the polls, and the problem is that duty then gets to be so big and flabby it doesn't mean anything anymore. And that's what I mean by making my concept less capacious, when it gets...
That's an MIT economist.
Yeah, exactly. They're in the building next door to us, so that's why. Yes.
And maybe following up with that, I'm just curious what your thoughts are on how there are well, maybe conditions is the right word in multiple senses of the word. Are there other conditions that exacerbate policy problems and just the state of problematic caregiving? And I have in mind specifically how mental illness on both ends of the age spectrum tends to exacerbate healthcare costs, and how yet the policies that we do, or in most cases don't have, complicate the problem of providing childcare and elder care. I'm just curious what your thoughts are.
Yeah. Yeah, there's, all kinds of difficulties individuals face that we don't really accommodate very well, and it's sort of like one size fits all kind of policy making. And I know, I guess the kind of, the piece I know most about is more like the sort of Alzheimer's and dementia piece, if you want to call that mental illness. Although I don't know if you were thinking more about other forms of mental illness like depression and, other conditions.
Well, I was considering Alzheimer's and dementia, also depression and bipolar schizophrenia, but a lot of those tend to be comorbid as well. They show up and they exaggerate each other's traits.
Right. And I think, we know that caregivers, for example, are more susceptible to depression and other mental health challenges like that, and yet we do so little for caregivers. And so I think, the mental health piece just makes the make the needs part of the equation just that much more acute, that we're not doing enough for people with, say, dementia, and then we're not doing enough to relieve the caregiver burden, and so adding to the potential for stress, anxiety, and depression in the caregivers. So I think it adds to the puzzle, like given the nature of these needs, and for child, I'll leave it there. I think it just adds to the puzzle that we don't do more given the huge need. That's not a very good answer to your question. I'm sorry. Yes. Sorry. Well, I'm going to take a question from him because you already had your chance. Then I'll come back to you. Yeah.
I was wondering if you could speak more to the problems in caregiving being emotional work rather than just physical work, because caregiving, you're not just taking care of someone's bodies, you're taking care of also the person, their emotional needs. So you think of elders who don't want to go into nursing homes because they don't want to be taken care of by a stranger, that they don't feel, they might have their physical needs taken care of, but they don't feel cared for. And how do we balance that need of children and elders to feel cared for with the emotional exhaustion and working of potential care?
Oh yeah, and I would never want to suggest that for every family that you would necessarily want to use outside caregivers. I mean, there's always going to be families who have a very strong commitment to caring for their own family members, but I think we have to support people in that highly emotional. I'm seeing this now because I've got both a mother and a mother-in-law who are in the process of, we're starting to recognize their need for care. And it is highly emotional because this person who was always the pillar of strength in your family is now the one who needs the care and who is scared and frightened of losing control and resistant naturally. I sympathize with the desire not to lose control. And so I think if we just had, so that's why I think it's not just, the piece that I would like to see more public policy on is not just how do we care for the older people, but also for the caregivers. Ironically, my mother, who we have to figure out what to do for her, used to run an adult daycare program. And the whole point was, if you could take your parent there and they could have, interesting programming and be well cared for and have a good meal in the middle of the day, and you could go to work. If you just had that 8-hour break, it made all the difference in the world and helped just provide the mental respite as much as the physical respite for the caregiver. Sorry, no, I will eventually get back to you. Richard.
I wonder how far back in American history you might have to go to find answers for the very important questions you raised today about care. I'm thinking of an argument that the historian Richard Hofstadter made in a book that he wrote on the decisive triumph of social Darwinism in American culture. And he concluded from that triumph that what we have here is a democracy of cupidity, not a democracy of fraternity. And in a democracy of cupidity, care issues don't rate very high. And I'm just wondering if there's a historical dimension to your political science undertaking here.
Yeah. Well, yeah, the funny thing is, obviously, we have a very strong work ethic in the United States, and the way most people manage, the way you support your families through hard work and so on. And I think one of the other kind of ironies in American politics, and this goes back, a very long way, is we value work so much in the United States, and yet we do so little to help people work. And it's just very odd to me. So imagine if, you have people in the workforce and you want to facilitate their ability to work, and yet you don't give them the maternity leave they need right when they have a baby at first. And you don't give them the paid sick leave they need or the paid days off when their kid is sick. Or you don't provide these programs that would allow family caregivers to still go to work during the day and yet then come home and take over caregiving responsibilities. And so it's this long-standing political culture or history of a strong work ethic in the United States paired with lack of supports for workers. And it's just kind of mystifying to me. You would think that we would have the most expansive set of helps for workers, given how much emphasis we put on work, and yet we don't. We leave it for individual families to figure out and cobble together.
So your question is, what are the levers that might help account for policy stasis?
Yeah.
I think he might have suggested one that's maybe more important than was initially obvious. And I would not use the Affordable Care Act as an example, but rather the Clean Power Plan.
Okay.
Which you will not be so aware of on the Atlantic coast, but we really are aware of here. And the point of that case would be that when it was proposed, there was a veritable avalanche of resources thrown out against it. Rightly or wrongly for the moment, but just boom. And there are a lot of resources available. And as Jane Meyer has outlined, those resources reach into think tanks and now academia. And their intent really is to stymie that policy initiative. And I'm not sure if it's fair to say by any means available, but some would argue that anyway. I'm not sure that that's fair, but certainly full board. And I think you might find that in the last generation or so that we've seen a lot of that going around as an offshoot of Mayer's dark money, which really kind of points the finger at one side, but actually often acknowledges that there's kind of the same forces on the other side. And just the willingness to say, to do whatever, just to stymie a policy might actually be seen to be, I don't know what you do with it once you say that, but I bet if you look at it from that light, you would say that actually is an important actor. And you can think of lots of examples where that's been the case.
Right, I think you're probably right. Another characteristic of American politics that also stymies just policy change in general is just simply polarization, sort of gridlock between the two parties and the inability to compromise and sort of all-out opposition to a policy idea from one side. If it originates with one side, it's sort of almost now immediately dismissed by the other side as opposed to trying to find common ground. And you would think in these caregiving issues, you might find common ground between Democrats and Republicans and liberals and conservatives, because what you're talking about is not only facilitating work, which is something that I think everyone can agree is a good idea, but also facilitate, helping families, and if we're going to have family values and hard work in the United States, you would think there might be interest on both sides of the aisle of supporting that.
Certainly in the sixties we did that.
Yeah.
You might say that Clinton was able to do that with his welfare initiatives. That maybe didn't work out very well, but it was still, it's a,
Yeah. I think the one thing we're just kind of tiptoeing around is the expense. You're asking you're asking owners of businesses to grant maternity leave, and then they would have to hire somebody. I mean, I'm for it. I think it's a wonderful idea, but we have to face the problem head on. How are we going to let these people know it will further their economic well-being?
Yeah, that's a very good point. And I would never suggest, we also know that very long parental leaves and maternity leaves not only are problematic for businesses, they're problematic for the individual. So for example, in some European countries, maternity or parental leaves are really long. And what that's meant is that women can't advance in their careers because they spend too much time out of the workforce. So that's the downside. But I think there's like a sweet spot, at least, for the individual. Like you don't want it to be too long, but you don't want it to be non-existent. So there's probably some, the peak of the curve. California is a pretty interesting case study because they do have this paid leave now, and one of the concerns of businesses was like, what are we going to do for the 6 weeks when this employer is out? And so surveys of employers taken after the implementation of the law showed that for very small businesses, it can be problematic because you don't have the personnel to cover the person who's gone. But the businesses don't have to be, that for the most part, except for very small businesses, the disruption has not been prohibitive. And that the outcomes in like not having employee turnover, like having to figure out how to accommodate this person's 6-week absence costs less than having to replace that person and train a new person. So it is disruptive, but it's not, surveys are showing that it's not catastrophically disruptive for a lot of businesses. So you had your hand up in the orange, yeah.
I may be missing the point here, and not as cerebral as some. I don't have a lot of political background, but I have a lot of caregiving background. And when you talk about the citizens groups, I know a lot of people who have been in those positions where what do we do? Somebody's not well anymore, more elder care things than child care. But it seems to come down to me, a financial activation on the citizens themselves, because they're going, well, to get something changed, and you talked about the confusion, who do we go to, where do we start? But there's also that big financial piece involved in doing any sort of legislature or policy making, or hiring the legal person who can tell you where to start. Because I've talked to so many people and they're like, we're not making ends meet right now. And I work with people and it's like, we don't have time to become involved in this big need because we're too needy ourselves. And that's maybe a different piece than we're looking at here. But the last lady that I took care of in her home, I made some phone calls, and their insurance and their Medicaid and stuff was willing to pay if she wanted to go into the nursing home, they would cover her. But they didn't want to make that choice. If they were not, they were not willing to pay if she were to have people come into her home to care for her. They were only willing to pay if she went into the institution. And when I pushed a little bit and traveled up the line with this, the final answer I got was, it's not financially sound for us to pay individuals to go into our home. That doesn't make any money. If she goes into the nursing home, then it financially proves out. So there are a couple things involved in that. But, it's a big, just getting involved in making a difference takes a lot of time and money. And for those in the greatest need, maybe, for this. And maybe the most useful at that level, the elder care level, or the lower income child care level. That's huge.
No, absolutely. Like, for citizens, two of the most important politically relevant resources, as we political scientists call it, are time and money, and they're both short for caregivers. So it's, it's hard to have a grassroots movement of caregivers because they're busy and they're strapped in every way. So absolutely. What was that? Yeah.
Pieces, in the end, do we want to help with these policies? Do we want to help people?
Yeah.
Yes, but in my final outcome was, we want to make money, which was.
Oh, yeah. Yeah, and then the whole nursing home versus home health care thing, so that there's just different policies state by state, and many states have gotten permission from Medicaid to use some of their dollars that would have gone for nursing home care for home health care. But then if you get to a certain number of hours in the home, it is in fact more expensive than institutional care. And so what some states have done is said, okay, we'll have home health care, but they'll have like really low number of hours per day that are so low that it just doesn't work for many people, and they end up in institutional care anyway. So it's really a struggle for the states. And the thing about Medicaid is that Medicaid, next to K-12 education, Medicaid is usually the biggest line item in state budgets, and then within Medicaid, elder care is the biggest, because the kids and low-income, usually mothers, in some states, parents who are Medicaid recipient, like they're younger and they're cheaper per person, but obviously, long-term care costs much more on a per-person basis, and so this is a big budget buster for states. And yeah, there's lots of states where you get like 2 hours of home care per day, which doesn't help a lot of people, or not enough for a lot of people. Yeah.
Just piggybacking off of her comment, it's sort of a chicken egg question within comparable European countries. Most people in Europe don't work full time. They have more time to be engaged.
Well, their definition of full-time is less than our definition of full-time is the other way. Yeah.
So, if we weren't required, because I think more often than not, you have both parents or both adults in a household working constantly and still getting nowhere. And then when you get home, you don't want to have to engage in these political issues. You want to just sit down. So I don't know if Europe has, or most countries in Europe have a better situation because they work less and they're able to engage more, or if, what's...
Yeah, that's a good question. Yeah, I should say on the working hours thing, if you look at households as units and the number of hours worked by a household in the US versus Britain, or US versus Europe, it's like 30 hours difference, like between two workers. Yeah, so why? So this comes down to like how much of the political pressure has to come from citizen activism versus should we expect lawmakers kind of on their own to figure out like they should do this, right? And so I think in Europe, a lot of the pressure has not in fact necessarily come from citizen activism. It's come more from, over time, mostly parties of the political left, although in some cases parties of the political right, enacting these social policies because they sort of view it as good policy. So it's not necessarily like, it doesn't necessarily have to all come from citizens. And you can see, like in the United States, like where might we get the leverage for change? It's hard to say that it's going to come from citizens because of these, time and money shortage issues we just talked about. And so we can only sort of hope. One hope is that when lawmakers experience something themselves, there tends to be policy change. So during the Reagan administration, there was a reform of Medicare. It didn't last very long, but the way Medicare is structured is, there's, as you may know, there's a lot of cost sharing. There's a lot of out-of-pocket costs associated with Medicare, and there's no cap on what those out-of-pocket costs can be. And so Medicare only there's 20% co-pays on medical devices, there's 20% co-pays on doctor's visits, there's deductibles for hospital stays. Some people have Medigap insurance that covers those out-of-pocket expenses or offsets them, but many people don't. And so regular Medicare just by itself could leave you, if you had a very long hospitalization, could leave you on the hook for catastrophic levels of out-of-pocket expenses. And so there was a reform during the 1980s to put a cap on these catastrophic expenses. And the motivation was that the Secretary of Health and Human Services, his wife had some catastrophic form of cancer, and they themselves encountered these huge out-of-pocket costs. And he's like, there's a problem with Medicare. And so when it happened to him and his family, he saw the light and proposed this change. So the change got repealed. That's all complicated. But maybe if we have more younger legislators who are trying to care for children and older legislators who have, caretaking responsibilities at the other end of life, maybe things will change. Yes.
I'd like to follow up on Professor Drake's invoking history as being perhaps an important factor in understanding the situation that you described so exhaustively. And I hope you feel comfortable my taking a historical perspective on where the USA is at the moment. And I think of the early settlers who almost eliminated the native population, and they're not doing very well at the moment. And then, of course, there's another group of African Americans that came in for a few hundred years, and they were subjected to slavery. And we've dealt with that in a halfway manner. I think perhaps you would agree. In more recent decades, President Eisenhower warned us about the effect of the military-industrial complex on the future of our country. And that, of course, has really burdened to the point where our military is supported by at least as much as all the rest of the world combined. That was, of course, quickly taken up by the corporate elite, and they are intertwined now in a very strong union. And so it seems to me now, with the selection by the Electoral College of a new president as the head of a neo-fascist GOP, with his main advisor at his side, who was a rightist of the worst sort, with racism, nativism, white supremacy, and even anti-Semitism thrown in for good measure. Do you really expect much from the Trump presidency?
Well, I have to say, at the moment, the Trump presidency, in policy terms, is a moving target. It's hard to know what. I'm teaching an introduction to public policy class this semester, and of course the students are wondering about the policy implications of a Trump presidency, and so we started making a chart in class to try to help sort out what might happen in different policy areas. And so the way we were proceeding was to have one column sort of like what a populist sort of, if Trump represents a sort of populist argument or populist perspective, what does that look like? And then what is a sort of conservative Republican, like Paul Ryan branch of the party, what does that look like? And then what do, in terms of policy preferences, and then what are the sort of relevant interest groups in each area, what do they want? And it's really interesting because it's kind of like it's like one of those, it's like a one-armed bandit where you like do three apples come up, or is it like apple, apple, orange, as you like go through each of these three things. And it's, in some of these policy areas, the preferences all line up, and in some they don't. So, so let's take Social Security, for example. So, let's take Medicare. So Paul Ryan, with the budgets that he has put together over the last few Congresses, wants to turn Medicare into a voucher program. So instead of being an open-ended entitlement where Medicare covers the healthcare expenses of everyone who's eligible for Medicare, instead Medicare recipients would get a coupon worth some amount of money, like $8,000, to then go buy a private health insurance plan, and then if you want a plan that's more elaborate than what you can buy for $8,000, then you've got to pay the rest. And so that's what Paul Ryan wants. And AARP, if you look on the interest group part, is deadly opposed to that. So you have like yes, no, and if you look at like a populist candidate, like Trump has said, I don't want to harm Social Security and Medicare, which makes sense because some of his supporters are, receiving benefits from Social Security and Medicare, and with populist, most populist movements like social insurance. They don't like social assistance, but they like social insurance. So in this case, you've got, one yes and two no's. So it seems like we're not going to get Medicare vouchers. But then you look at Medicaid, and we were just talking about how Medicaid is a budget buster for the states. So Paul Ryan, again, looking at the sort of conservative Republican column in this chart, wants to turn Medicaid into a block grant for the states. Because the way Medicaid works now is the states and the federal government both contribute to the cost of Medicaid, but it is open-ended in the sense that everyone who's been deemed eligible in that state by the state can get covered, whatever that costs. And so he wants to turn that instead, and then the federal government does a match on what the state contribution is. So he wants to turn the federal piece of that from this open-ended match into a set amount of money. And we saw what happened with welfare reform. When states get a set amount of money, it's really easy to make that set amount of money shrink, either through inflation or by actually cutting it. So that's the conservative Republican preference, is to turn Medicaid into a voucher. The populist branch of the party, again, they want to protect social insurance, but don't mind cutting social assistance, and Medicaid is social assistance. So that's a yes for cutting. On the interest group part, I suppose nursing home industry would oppose it, but I don't know, you've got two yeses and a no there, so maybe it'll happen. The third category, and I'll stop here, is tax cuts, right? Paul Ryan branch, absolutely. Can't wait. The Trump branch, yes. Business interest groups, interest groups, if it's corporate tax cuts, yeah. If it's tax cuts for high-income people, sure. So there you've got a yes, yes, yes. So I wouldn't be surprised at all if we see big tax cuts under a Trump administration. Many other aspects are more complicated. I'll leave Professor Karen Adams can tell us about what's going to happen in foreign policy, because I have no idea. But I think we're in for an very interesting 4 years. I'll leave it at that. Karen.
I have been sitting here thinking about military spending and military strategy, and in my field in international security, we basically expect for suboptimal strategies to continue until there's a crisis, like you lose a war, you have a new competitor or something like that. It seems like although this, you've talked a lot about all of the ways that this is really a suboptimal policy milieu, that in some ways it's not really broken enough to be fixed because of the essentially unpaid labor of family members and the ability of middle and high income people to use their wages or their savings to meet their own needs.
Mm-hmm.
And so I wonder if you would agree with that characterization, or do you feel like the system really is in crisis right now, and so it really is a puzzle that we don't have better outcomes?
Yeah, well, I think the not broken enough does apply to some of the parts I was talking about, like the fact that middle and especially upper income families have figured out how to make the child care status quo work for them, and so on. And so the constituency for change being undercut by the half solution. So I suppose in some ways it's not broken enough. And the question is, like, how broken does it have to get? It's like the slowly boiling frog problem,
How would it get broken?
Or how would it get more broken?
So, for example, when I think about demographics, and there are more and more families, or more and more individuals all the time who don't have extended families.
Yeah.
And it seems to me that over the next 15 to 20 years, those people would constitute more of an interest group for more public provision of some kind.
Mm-hmm. Yeah, the demographic inverted pyramid that we're heading toward, maybe that'll be what really breaks the system. Because right now, the average family has more, how what is it? The average couple, I think it's the average couple has more elders than they have children. You know, so it's, and the ratio of elders to working age people is obviously rising. The US is in better shape than some of these other countries because we have somewhat higher birth rate than many parts of Europe. But yeah, maybe it'll get to the point where there's like simply not enough children to take care of the parents, and that'll be the breaking point.
Thank you for that, Campbell.
Thank you very much. Thanks, everybody.